Welcome, everyone. We're doing a deep dive today into nasal reconstruction, really focusing on hitting the key points for your board exams.
Exactly. We'll cover the essential anatomy, how to analyze defects, and the core reconstructive principles. No fluff, just what you need.
Okay, let's start with that basic structure. The nose, we divide it based on the underlying support, right, into thirds.
Correct. Proximally, you've got the nasal bones, then the middle third, supported by the upper lateral cartilages.
Yeah, distally.
That's your nasal tip, the alae, the membranous septum. And don't forget, the columella, its support comes directly from the medial crura of the ular cartilages. That's a key point.
Absolutely. So when you're faced with a defect, say in an exam scenario, thinking about the layers is paramount.
Right. Skin, then the soft tissue, down to cartilage or bone, and critically the internal lining. Each layer needs consideration for the reconstruction.
And the fundamental goals haven't changed. Maintain the airway, that's number one.
Always. Then replace missing layers with tissue if possible, keep morbidity low, and of course, optimize the aesthetics.
Good. Let's talk blood supply. It comes up all the time with flaps.
It does. So laterally and caudally, think angular artery.
Okay.
The sill, septum, base of columella, that's mainly superior labial artery territory.
And the dorsum.
Dorsum and lateral skin get supply from the dorsal nasal artery. And you also have contributions from the infraorbital artery to the dorsum and sidewalls.
And the veins just follow suit, generally. Knowing this is crucial for planning flaps, ensuring they'll survive.
Definitely. Now, sensation trigeminal nerve, V1 and V2 divisions mostly.
So V1, ophthalmic.
Yeah, V1 covers the upper parts radix, rhinian, cephalic sidewalls, dorsal skin down towards the tip.
And V2, maxillary.
That gets you the lower lateral nose, the columella, and the lateral vestibule. Useful for nerve blocks and assessing deficits.
Motor function is simpler, mostly facial nerve, controlling things like procerus, nasalis.
Exactly, CNCM.
What about the skin itself? It's not uniform.
Not at all. Big difference. Upper two-thirds, generally thin, loose, pretty mobile, not many sebaceous glands.
Easier to work with in some ways.
Sometimes. But the lower third that's thicker, less mobile, packed with sebaceous glands. Think tip and ala, much thicker skin than, say, the dorsum or columella. Those differences matter for grafts and flaps.
Okay, so we see a defect. How do we break it down systematically?
Key parameters. Location, obviously. Then depth. Is it just skin, or does it go deeper, involving cartilage, bone, or that crucial lining?
And size, the dimensions.
And the dimensions, yes. That tells you the scale of the challenge.
This leads nicely into aesthetic subunits, Burgett and Menick's concept.
A very important concept. Viewing the nose as these distinct regions, dorsum, tip, alae, sidewalls, columella, soft triangles.
And the rule of thumb is often if the defect involves more than, 50% of a subunit?
Then consider reconstructing the entire subunit. The idea is that scars placed between subunits are better camouflaged.
Using the contralateral side as a template. Makes sense.
It does, but it's not without controversy. Roerich and others advocate for a more conservative approach, sometimes reconstructing only the defect itself.
Right, the defect-only idea. Maximal conservation, complementary procedures like dermabrasion, maybe primary defatting favoring axial flaps.
Exactly. Their endpoint is good contour. You need to know both philosophies, really.
Okay, lining reconstruction. You mentioned it's critical. Why so much emphasis?
Because without a stable, vascularized internal lining, any structural grafts or external coverage you place are basically doomed. It's the foundation.
So what are the main techniques?
Lots of options depending on the defect. You can use local tissue, like a turn-in nasal flap hinged near the edge.
Flipping local skin inward.
Precisely. Or you can bring in tissue from outside, folding in part of a forehead flap or a nasolabial flap.
Can you graft the lining side of a flap?
Yes, you can place a skin graft onto the deep surface of a forehead flap, for instance. Sometimes you might even include cartilage or palatal mucosa with it.
What about using the septum?
Several septal options. The septal door flap uses cartilage hinged, usually dorsally, with contralateral mucosa. Its reach caudally is a bit limited, though. Then there's the septal mucoperchondrial flap, often based inferiorly. Pivots out. Can be mucosa only or composite.
Good for the vault area.
Can be, yeah. And for small alar lining defects, there are mucosal advancement flaps, bipedicled from the septum and piriform aperture.
And the septal pivot flap.
That one can give you both lining and some dorsal cartilage support. Quite versatile.
Moving on to the framework, the skeletal and cartilaginous support. Any key dimensions to keep in mind for the nasal bones?
Well, they're widest up high, near the nasofrontal suture, maybe 14 millimeter. Narrowest point is around 10 millimeters. Thickest superiorly, about 6 millimeters, thinning down towards the tip. Relevant for things like screw placement, if needed.
For midline dorsal support, what are the go-to methods?
You could use a strut graft bone or cartilage from radix down towards the tip, hinged septal flaps, L-shaped. We mentioned the septal pivot flap already. Or a cantilever graft, often rib cartilage or bone, fixed proximally.
And supporting the ala seems crucial for preventing notching or collapse.
Absolutely. You can aim for anatomic reconstruction, shaping autogenous cartilage to mimic the lost lateral crura.
Fixed medially.
Right, to the medial crura or a columnumellar strut. But there are also non-anatomic techniques.
Like ulnar batten graft?
Exactly, for alar collapse or external valve issues. Placed caudal to the lateral crus position, extending towards the piriform aperture.
And lateral crural strut grafts.
Those are more for a fellar rim retraction, placed between the remnant lateral crus and the vestibular skin.
Okay. What about LR spreader grafts?
Used for a pinched tip or internal valve collapse placed between the upper lateral cartilage and the septum, effectively widening that angle. Though some use them more laterally too. LR contour grafts are another option, just for shape and some external valve support.
Can you use alloplasts here? Things like Medpor or mesh?
You can, often combined with autogenous tissue. Titanium mesh for a dorsal framework, porous polyethylene as struts or sheets. They offer structure and are readily available.
But the downsides?
Higher risk of exposure, infection, extrusion compared to autografts. You have to weigh that carefully.
Okay, let's talk skin and soft tissue coverage. This depends heavily on the location, glabella or medial canthus.
Small defects there, less than a centimeter, might even heal well by secondary intention. Larger ones might need a globular flap.
Dorsum inside walls. Lots of options here.
For sure. Small defects, maybe a banner flap. Bilub bed flaps are common for defects up to maybe 1.5 centimeters, especially in thicker skin. Remember the Zitelli modification?
The dorsal nasal flap.
Good for lobule defects under 2 centimeters, keeping about a centimeter from the rim. Axial flaps like the front nasal can reach the lobule too. Chic advancement for sidewalls.
Nasolabial flaps seem versatile.
Very superiorly or inferiorly based. Can cover alveolar or lateral wall defects, though they might need cartilage support later. Turnover flaps for lining. Sliding flaps, lots in the toolbox.
But the workhorse, especially for larger defects of the tip, lobule, or subtotal reconstruction.
Still the forehead flap. Midline, or more commonly now paramedian, based on the supratrochlear vessels, sometimes supraorbital too. Dissection through specific layers down to periosteum is key.
There are modifications too, like expanded flaps, gull-winged.
Right. Scalping flaps, sickle flaps are older techniques, less common now due to pedicle issues or requiring delays. Washio flap from the temporomastoid region is another option, using postauricular skin.
What about just skin grafting?
For superficial defects, less than a centimeter maybe.
Hmm.
Best in non-smokers. Forehead skin often gives a decent color match. Dermabrasion can help blend edges.
And composite grafts, ear cartilage with skin.
Yes, chondrocutaneous grafts. Good for small, full-thickness alar rim defects, usually up to 1.5 centimeters. Donor site is typically the ear helix or antihelix.
Columella reconstruction. Seems tricky.
It is. Bilateral nasolabial flaps tunneled in, forked flaps from the upper lip, especially in older patients, vestibular flaps using internal lining, even an extension from a forehead flap or composite grafts.
And the soft triangles always seem delicate.
They are complex shape. Reconstruction needs careful planning, often borrowing principles from adjacent subunits.
What if the whole nose needs reconstruction? Total nasal defects.
That's a major undertaking. Often involves prefabrication, building the lining and framework under a large flap, usually the forehead, before transfer.
And if the forehead isn't available?
Then you're looking at free flaps. Radial forearm is a common one. Others include serratus, anterior fascia, dorsalis pedis, postauricular flaps. Options exist, but are more complex.
Okay, let's shift gears slightly. Rhinophyma. What's the quick summary for boards?
It's sebaceous gland hyperplasia leading to that bulbous, enlarged, often red nose.
Primarily effects.
Much more common in men, typically older white males, maybe 60s, associated with severe acne rosacea.
Not directly caused by alcohol, though. That's a common misconception.
Correct. No direct causal link proven, though alcohol can exacerbate the flushing. Important to remember there's small risk of malignant degeneration, usually to BCC.
The stages.
4 stages described: pre-rosacea, flushing, vascular redness, telangiectasias. inflammatory papulopustules, and then stage 4 is rhinophyma itself.
Treatment, non-surgical first.
For earlier stages, yes. Sun avoidance, hygiene, maybe tetracycline, topical metronidazole. Isotretinoin can be effective but needs careful monitoring.
And for stage 4, the rhinophyma.
That's surgical. Tangential excision is the main approach, shaving down the excess tissue. Can use a cold knife, dermaplaning tools, dermabrasion, CO2 laser for hemostasis.
Goal is to get down to the underlying cartilage framework.
Generally, you preserve the deeper sebaceous elements for reepithelialization. Outcomes are pretty similar between the different excision methods, and crucially, send the excised tissue for pathology.
Good point. Always send the specimen.
Always.
Okay, so wrapping this up for board review purposes. Key takeaways.
Understand that layered anatomy, skin, soft tissue, support, lining. Know the blood supply and innervation territories. They dictate flap design and potential deficits.
Master defect analysis, location, depth, size.
Absolutely. And the principles of reconstruction. Lining first is often most critical. Have a solid grasp of skeletal support options, both autograft and the potential role and risks of alloplasts.
Be familiar with the main flap options by region, especially the workhorse forehead flap.
And understand the aesthetic subunit concept, but also know the alternative defect-only reconstruction philosophy. Be ready to discuss both.
Sounds like a solid review. Hopefully this helps focus your study.
Agreed. It's a complex area, but breaking it down systematically helps. Good luck to everyone preparing.